it's a TAVI complication. It's a bit slow. Okay, it's working. It's slow. Okay, it's coming. So this is the patient record. We have electronic patient record. This is the patient I treated end of December. It's a VIP patient, very VIP, and it's the first time I have this kind of complication. It's a bit slow. Connection is lost. You have to stay close to me. Yeah, because if you use your phone, then it will disconnect it. You just leave it there. Sorry.
Lấy mạng mình đi em, lấy mạng mình không?
In the meantime, I can show you something else. In the meantime, I show you something else. In the meantime, this one. No, not this one. Oh yeah, maybe I show you this crazy case. Okay, I show you this one. This is not a complication, but this is a bit. It's not working. It's not. I usually don't prepare. This is a patient. He got surgery for. It's a young guy. He's in his 50s. Surgery for this prolapse. You see the 3D images. Are you used to see the surgical view? Typical surgical view of the mitral valve. So here we have the interatrial septum, the mitral valve, the prolapse you can see here. This is the left atrial appendage should be there, but I don't see it. The aorta is always here. This is the view that the surgeon has when he opens the chest. So this is before surgery, I think. I hope so. Yeah. It was endocarditis, with some prolapse at least. So this is his treatment when he leaves. I didn't prepare the lecture myself, so I don't like this, but with all this thing. But you see that there is something wrong, you know? Can you see the problem? So he has a bioprosthesis for the endocarditis. Yeah, he had this is the bioprosthesis. So he changed his valve, and this is a new valve. So this is a bioprosthesis. You see the annulus of the bioprosthesis here.
Yeah.
Here the annulus, and you see the bioprosthesis functioning.
Yeah.
But there is something definitely wrong now. You see?
Something moving.
There's something moving, yeah. There's something that should not be there.
Yeah.
What is it? You see it? This here. This.
Yeah.
So what is this?
What is this?
What is this? A few weeks after surgery. Can be endocarditis, can be a new endocarditis, vegetation. What can it be else? Thrombus, huh? Thrombus or vegetation. Yeah. So they say it's a thrombus after 2 months, and I think they give some. Here are the options. What can you do? No, don't do that. So these are the options to give some treatment, to reoperate the patient. I was not involved at that time. Here you see the. So they put the patient on anticoagulation and aspirin. Okay, and they also give antibiotics. So, but the patient has no symptoms. So, what is the risk of this patient? If it's what can happen with this What is the potential complication of this thromboembolism? Yeah, so he can have a stroke. The stroke is the so after 3 weeks, it's still there. You see, it's even like look, it's like bigger.
Yeah.
And if you look, I don't know if you maybe I'll go back, but something has changed. I'll go back in time. So let's look again. Basically, at this moment, it's very important. Something has changed. Look at the position. At where is the at where it is in this position. Keep it in your mind, and then we advance. And then I show you. Keep this in mind. Still, it still has not changed. And now I show you the next. And now there is something new.
To the opposite well.
Yes. Well, not really correct. It has moved position, but where has it gone now? So what do we have here? This is the which valve do we have here?
It's out of valve.
The aortic valve. So we call this the LVOT view, left ventricular outflow tract view. Okay, left ventricular outflow tract view, and now we have it here. And where was it before this filling defect? Before it was somewhere else.
It's on
Opposite, yeah. But this is the ventricle. Everybody agrees?
Yeah.
This is the aorta. So what is this here?
Atrium.
Left atrium. So where was this filling defect before? Opposite, but how to say it properly?
Same size.
SEM is still something else. SEM is the just 1 second. I'm just is the for because tomorrow I have to give a lecture on how do I answer this one like this?
Yeah.
Okay, thank you. Ok. Allô, Sadia? Oui, bonjour. Je suis juste en train de donner un petit talk pour le médecin du Vietnam. Je peux vous rappeler après? Ah, ok. Ok, magnifique, c'est super. Magnifique. Ok, merci beaucoup. Vous êtes répété. Merci, au revoir. Tomorrow I have to give a lecture on OCT, but I don't have any slide. So I asked the lady from Abbott, and she just tells me she sends some slides. So I have some slides now. There is a score by a Japanese doctor, but I don't know this score on calcium. I will learn something before tomorrow. So if we go back, before it was in the left atrium, and it moves from the left atrium to the left ventricular outflow tract. So in this situation, I was called by the cardiac surgeon, the head of cardiac surgery. The patient is 53 years old, and there is no sign of endocarditis. There's no and the patient has no symptoms. So he has no fever, no inflammatory markers, nothing as a sign for endocarditis. And the belief is that it is a thrombus. So they believe it's a thrombus, and the patient and the surgeon says, I don't want to operate the patient again. So then the surgeon asks me, can you take this out? But how? So the surgeon tells me, you try to take it out. I said, this is not, I don't agree, this is not okay. And then he said, I don't want to operate the patient anymore anyway. So I remember that was I think about 1 year ago, and I had to go to a meeting, and so when I saw the patient for the first time, it was in this situation. So this situation, when the thrombus was still in the left atrium, and so what my idea was to use a steerable big catheter to go transeptal puncture and to connect it to an aspiration system, and then to inject it through the femoral vein. This was our idea. And I talked to the patient agreed, But then I went to a meeting and in the weekend, and when I came back on Monday, the thrombus had migrated to the outflow tract, this one. So now, of course, from the transeptal, it is not possible from transeptal to aspirate this. So so what then the surgeon told me, it's a bit crazy, but you know, when I came back on Monday, they scheduled the patient for me, but they didn't ask me if I agreed to do. So, and the surgeon said, I go transapical, and then you use the catheter, and then you aspirate. So yeah, the patient was on the table before I could make my opinion. So this is what we did. So this is the patient on the table, and the surgeon will make a small cut down. You see, and what is the problem? What can happen? What should we do? What should we do? What can be the complication if you try to aspirate this thrombus? What can happen? Yes, it can embolize, and where can it embolize? What we said before, in the brain. So what we used the Sentinel, which is like a protection device for TAVI. It's like a filter. So we put one filter here.
Two filter?
Yeah, we from both radio.
Yeah.
So from here we put one filter. The Sentinel, I don't know if they have a picture, but because this is a surgical intervention. So, and this is how we are working. So I think I'm somewhere here. I don't know where I am. The surgeon is there. And we put the Sentinel. This is the filter here and there. So there is one in the truncus and one in the carotid. And then on the other side, I put also a filter, but I only left it in the subclavian artery. So the brain is not quite well protected. And then this guy is the surgeon. This is me a little bit behind there. Is the surgeon, is the assistant. And we make this kind of connection. Yeah? So with the surgical approach, we just do there's a transapical puncture. And then I use this thing. This is 14 French, and I use this one to close the paravalvular leak. So when you steer this wheel here, then the angle will change. You can make it larger or smaller. So this angle can be changed, and you can rotate it. And this is set here. So the surgeon introduces it, and then I will try to go to the valve and then try to aspirate it. So this is the setup. So transapical. Then we have this catheter. I show you here. This catheter.
Outside with French.
14. So 14 French. But and then here is a big valve. So I will connect this valve to the surgical system. So the surgeon will give me a cannula, and then the cannula will be introduced into the sheet, and then introducing this sheet, and then the cannula goes here to a vacuum. There's a filter, and then re-inject it in the femoral vein. Okay, this is what we did. So and this is they filmed it with the I think they filmed with the smartphone. This one you see here. Yeah. So and you will see. I don't know where I am. We are doing this here. Yeah, and yeah, I think this is the next image. Why is it not turning? Oh yeah, okay. You will see. So here comes I think my catheter will appear. Here you see my catheter appear, and I can take it out immediately. You see it there. Now it's gone. Yeah, it's very easy.
Yeah.
Very quickly.
Capture.
Yeah, it's very easy, honestly.
Yeah.
And then the valve was clean. So this is after. It's gone now. And this was more than 1 year ago, and the patient's still fine. So this the young doctor from surgery. He presented everywhere in the world. But I honestly, I don't think this is something we should do. We did it, you know. the patient is fine, but yeah, I think it's a bit, I don't know, it's a bit a strange case.
So what you
Also, there was the filter, but in the filter we saw, in this filter, we saw a lot of small particle, but no thrombus, because the vacuum is very strong, so it destroys the thrombus. So there was nothing to see. A little bit of, I don't know how to say.
So you will use a French protection. If
Yes.
you do filter.
Yeah, I think that was important.
The
to-
left
Yeah.
carotid artery, one in the no artery. You did 14
French.
14 French shape. Yeah, from the apex across and into the left chamber, right?
Mhm.
And under the ultrasound guidance, capture the purpose.
Yes.
Yeah.
Because you can deflect this
But
system.
actually, I saw you did look very easy, but
It's not so complicated.
Yeah.
No.
But it's really easier to capture.
Yes.
Oh, yes.
Because you see on the echo, on the
Ah.
second, so I turn it and then I advance it, and I think it was.
Yeah, you had
Look, it's not
had
working.
to the
I cannot
you,
get Wi-Fi.
Wi-Fi. You didn't try too much.
Đúng rồi, phải này.
Yeah. You see, I have no more connection.
You use it, yes. Yeah.
Which one? Which one?
Yeah. Which one?
Look,
I see.
5G.
But now I'm in again. Right?
Yeah, I think it's the
Then you need to put the password.
yeah.
Yeah, you need to put the password. Yeah? Okay.
Press solo. Yeah.
Be careful because they can read the password.
Cái máy này chưa có máy.
Still connected.
Still connected.
Yes. Okay. Let's see.
And not yet.
Yeah, because now it's connected to the phone of Loka.
Connect already. Enough. We check. Okay.
I don't know. It seems to be connected to my phone.
I'll
just
forget it.
I just disconnect my.
Em coi là cái không em coi là cái wifi mình coi được chưa? Em kiểm lại.
Connect, yeah.
Đạt là bấm vô.
You have to do like this.
Tắt cái quen đi.
Maybe you need to disconnect or something. Yeah. You disconnected?
Yeah.
I'm disconnected too. One moment. Disconnect here too.
Synchronize with your iPhone, right?
Yeah, I disconnect my iPhone here. But why is still? Shouldn't be.
Turn off it and then try it.
Wi-Fi.
Nó vô.
Nó nhớ cái cũ.
Yeah. Now.
Yeah, we need to forget it.
Yeah.
US Wi-Fi.
Yeah.
US Wi-Fi and then connect to new one.
Yeah, I think.
Very much okay.
Okay, I'll do this. Which one was it? The second?
Yeah, yeah, okay.
5G.
Yeah, now you can put the password. Yeah. Let's see. Otherwise, I have other things I can show you. You have to, yeah.
Okay, you get it.
Yes, seems to be coming.
Anh ơi, 2304 thôi chứ không có 1974.
Hả?
Không có 1974.
Sao?
Hồi xưa 2304.
Doesn't work. Doesn't work. Let me.
Anh bỏ cái năm sinh của anh đi.
Let me.
Ngày
Bây giờ là gì?
ngày tháng thôi.
I think, but it works.
2304.
Trời ơi, sao?
Anh quyết vậy đổi.
Chứ trời ơi, là cái gì? Đại đánh là cái gì vậy?
Đọc lại anh.
230 474.
Hử thôi.
Trời ơi, vậy thì phải đổi cái password. Mày biết hồi nào thì tại sao không nói với anh?
Yeah, it's working.
Dạ, xe ở anh.
nó iPhone nó có chế độ tự xe,
Ok.
họ có chế độ xe hết, anh nói chuyện anh hỏi luôn vậy à.
Thì đâu nữa.
Okay, I tried it. Okay, it's fine. It should be quicker now. Oh,
Hả?
maybe ask me for the code again. This one I had before. Yeah? This one. I think this one came before, no? Yeah, but I had this one before. Let me check. So nobody knows how to use the old Nokia anymore.
Yeah.
You want?
Nokia.
Okay.
Nokia,
9,
yeah.
2, 3, 9, 9, 4. I will show you a complication I had just before New Year that I never had before.
Hello, son.
Yes.
Oh.
Okay, in this patient. Password all the time. And the patient is very, very VIP. Very rich.
Để.
But still quite nice. Yes, no checking. Yeah, okay, here we are. Ah, finally. So this is really the big advantage that is on 25. Yes, okay. Okay, this is the angio. So we have a kind of what we call the back swap. So this is the we have all the cases we do. We can review them. So I'll show you. So you will see immediately the patient has a pacemaker, a permanent pacemaker, and as you can see, we are supposed to do a TAVI. So I think certainly in your hospital in maybe 5 years you will probably also do TAVI. But this patient, the image is not so good. The patient has to have a TAVI. So what you see here is a first injection of contrast medium in the aorta with a pigtail. So this is there is a software that enables you to see the plan of the valve, that you are parallel to the different cusps. You can see that over here. Okay. So, and we have two views. There is one view that is called the cusp overlap view, because we are going to implant this is the core valve, the evolute. Okay. So yeah, this is evolute from Medtronic, is used in Vietnam. Yeah?
Yes.
So in that day we had 4 TAVI to do, and he was the number 3. So we did. The first patient was easy Edwards valve.
Yeah.
Then the second patient was valve-in valve for stenosis, bioprosthesis stenosis. And this third patient, and the lady doctor that do the case with me, he said, let's also use Medtronic valve. I say it's okay. There was some arguments for that. We could argue, so we need a CT scan in every TAVI patient. The reason is to see if we can go from femoral, because we need to at least 5-6 millimeter of lumen. We need to see the plaque composition, all that. We also need to see the size of the valve. We have a software to measure the surface of the valve, and then depending on that, you will use a bigger or smaller valve. The bigger the annulus, the bigger the valve. Okay, and it's really important to have good measurements. There is a software that does that for you. And then the other thing also is the software gives you the projection in which you can implant a valve. So the software will tell you, for example, in this patient, you have to go mostly a little bit oriocaudal, then you see the 3 cusps, and a little bit alveocaudal till you see the 3 cusps well aligned, that you put the valve at the right position. Yeah. So in this patient, we decided to use the biggest valve from Medtronic, 34. But then the lady from Medtronic came and she said, no, 34 is too big, you have to use 29.
29.
29, yeah, a little bit smaller. And
But actually, you the plan to measure the valve, we have to perform before.
yes, of course.
The days
so
before.
when
meeting.
the patient comes for a workup for TAVI, comes always before, and we have the patient seen by the geriatrician, for the old patient. We do a CT scan, we do all kinds of things, and when all this is done, then we plan the CT. We have a valve board where we discuss the patient, and then we discuss the strategy. So this was decided to use 34, but then the lady from Medtronic said, no, 34 is too big, and I don't know why. I accepted her decision, and then you will see what will happen. So you will see a very funny complication. This is here we check if the valve is well prepared. The valve is prepared by the nurse, and then this valve is automatically deployed when you retract the membrane. You will see that. So here we are. So what's basically going on is that the Medtronic valve, there is a big thing you have to unscrew, and while you unscrew, this thing here will move up and it will open up the valve. Your company has the Allegra valve, is a little bit the same style. It's also a valve where you gently deploy the valve. It's a bit, you have the balloon expandable or the self-expanding valve. This is a self-expanding valve. The problem is that the image quality is not very good. So when you deploy, you use some contrast medium to see if the valve is at the right position. You see? And here we see that the valve is opening up, you see that? But if you look, this is the opposite, so it is not opening well, and the valve is a little bit too high, because here is the valve, so we have, in that case you can recapture the valve and put it a bit lower. That's what we did. So we recapture the valve and put it a bit lower. You will see that soon. Okay, so I think now we have recaptured and put it a bit slower. Okay, now the complication already. So now the valve is just
fully
back,
steady.
is deployed, but look carefully what happens. Just look now and tell me what you see. Look carefully now. Did you see what happened? Did you see what happened? I just show it to you. The valve is embolized. You see, this normally this is the nose cone of the valve, and normally you have to pull on this wire to get it parallel to the valve and then pull it out. In this case, the nose cone, what you cannot do is have the nose cone below the valve and then you pull it out. But here, the nose cone is parallel to the valve, and despite the fact that the nose cone is in the right position, it still pulls out the valve, which is, I've never seen this. So look carefully now, the valve has embolized, so it's much higher, and the valve is floating in the aorta. It's in the aorta, it's fully open now, you see? And I never had this complication before. So what to do? What do we do? So the first thing is you never lose this wire. Theoretically, if you use the Edwards valve, the balloon expandable, if this embolizes, it can flip around, and if it flips around, then the patient is dead. This valve is much bigger. This valve will not flip around because it's much larger. So, but the other thing is, the concern is that this valve can block the coronary ostia. So what you have to do is to snare it. So we have to do a second arterial puncture and snare this here to pull the valve up. So this is what I will do. I'm sorry, it's a bit, the internet is a bit slow. Here you see that the valve is completely embolized. The valve is here and it's above the valve, okay? So this is, I take a snare to try and catch the valve. You will see. Normally you should try to snare this. There are two buttons, one there, but I could not reach it. I just have a little bit here, and then I just pull up the valve. You will see. pull up the valve a little bit. And you see now the valve is much higher, you see? And now the next step is, of course, we have to put a new valve. So the lady from electronics say, okay, because of course, if now we try to put a 34 valve, this is very bulky, maybe I will have trouble to get through. So what you have to do is one person has to keep the snare and the other person has to put the second valve over the wire through the first valve, which is quite tricky. So the lady of Medtronic said, use the Edwards valve. So we use the Edwards valve, and you will see. You will see that soon. So we have a pigtail that was from radial here to see the height of the valve. You see, this is the pigtail from radial. You see that? And you see how small the valve is compared to the size of the organ. Way too small, you see? Okay, and you see here I make a mistake. I push the pigtail and I push the valve down. You see that? So what I did then, I put a wire parallel to the valve. I will see that. You will see that soon. You see how the valve is moving? This is the truncus here, and I just put a 4 French catheter, just against right, parallel, and then I can put a pigtail here. And then the next step will be to put the second valve. This is the Edwards valve. It's mounted on a balloon, and we push it through the first valve, which is a bit tricky, you know. But you have not seen something. The worst is to come. It's only the beginning of the problem. So then we will put the Edwards valve. You will see that.
The second is Edward.
It's Edwards, yeah.
No.
So no. The lady from Medtronic says stop.
Ah.
So the way you put the Edwards valve, you see this is a marker here and here. You leave about 1/3 inside the valve, and then you do the rapid pacing at 180 so that the heart doesn't move, and then you can implant the valve. Okay, this is what we do. So we're going to implant the Edwards valve. Now the Edwards valve is implanted already, and we have one valve there, and if you look at the angio, I think that just one strut of the core valve is just behind the truncus, and I hope maybe it will stuck there.
Yeah.
That was my hope, but we will see. So we'll do an injection. So the injection shows that the Edwards valve is fine. Is okay. Look here. No parabolic, and you see it's just behind the truncus there. So I hope maybe it will not move, and now you will see. So at this stage, I have to release the valve because I cannot keep the valve there forever.
Yeah.
So, and I thought if I release the valve, it will probably embolize again. And so what I show you now is after I release, you will see something totally crazy.
Unknown caller.
You're ready to look this? I show you. So crazy. So if you look carefully, the valve is moving up and down and is spinning around this axis, like this, doing like this all the time. You see that? So I tried to snare it again, which was quite easy. And this time I can snare the bullet here. And you will see that. I can just snare it. And now I have the valve here, okay? So now the point is what to do. You see this is calcium here. So we have, I think we have, this is my first embolization of core valve. I never had one. But my colleagues had 2, and 2 times the fatal outcome. The patient had aortic dissection and passed away. So I was very scared to have aortic dissection. So my idea is, here the valve is not touching the wall. So my idea, I think I will put on it and I will try to flare and open the valve. And it worked out. So you can see, I will just pull on the valve, and the valve will become bigger in the distal part. It will flare open. Yeah? But I think I was very lucky, you know.
Okay.
So, and then I flared it, and then it's not finished yet. So now the valve, this part is much more open, the distal part, but then I cannot release my snare because it's stuck around this bullet. There's one more complication. So, but I was lucky, I just shake a little bit and then at a certain moment it becomes free. You see it's stuck here. And then I can take it.
Yeah, it will be there forever.
Yes, forever. And you see the angel. So now the valve is open, is more open, is behind the truncus, and so this is 27th of December, so 1 month ago, and the patient is fine. And the patient, when we do the TAVI, the patient is not intubated; he's conscious. So the patient has seen everything.
Oh.
So after I explained him everything.
But maybe he's scared.
No, he's quite okay.
Because he didn't know that everything happened, all right?
No, he told me, afterwards I go to see him, I talk to him, and I tell him, we have this complication, the first valve embolized, we had to put a second valve, and then he tell me, I have heard everything, I followed everything, I understood everything.
Yeah, it's crazy that you put another valve.
No choice.
Yeah.
No choice. And the problem is when the valve embolized, my younger doctor, she panicked a lot. That was doing the case with me. And the first thing she said, "Oh, this is such a big VIP, and we have this big complication." And I said, So I'll show you another one.
Actually, I know that the topic will definitely develop 2 or 3 years later because of the price is cheap and also a lot of the kinds of product will distribute in Vietnam. So it means that the alcohol have to do with it.
Yes.
But actually, I also know that it's not difficult to do.
Not so difficult.
Yeah, it's not difficult to do. But actually, I don't know how can I start with the one? Yeah. How to set up.
The patients are everywhere. Huh?
The patients are
everywhere.
Yeah,
Many.
I think the potential.
Many, a big potential. How to start? You have to get finance first. You have to send somebody for a training somewhere. So this doctor, there's a doctor from Chorai that last year when I came here, he talked to me and I sent him to a friend of me in the south of France, and I think he did like 300-400 TAVI. So he's now good. He's back in Chorai now.
Yeah.
He's very happy.
Yeah, he just turned back maybe before Christmas,
Yes,
and I heard that the Chorai has do the two TAVI cases, the first 2 TAVI cases after he turned back. They asked that, how about the hospital? You have any plan?
It is better, the guy in France, I know him, Julien is his name, and he has a lot of cases, and everything is much cheaper in France. Switzerland is too expensive. So the best is to go. I don't know why. This is the best is to send him. If you have some young doctor here who wants to train on TAVI, I can connect you to some people. So somebody has to be trained, and it's better to have somebody dedicated for TAVI.
Yeah, but actually, if we have plan and we have some young doctor, I want to send to study
in France, it's
in
possible.
France.
Yeah, because
Yeah.
I know Julien very well.
Yeah.
Because when I met this young doctor last year at a New Year party from Chorai, I talked to him, and then after that I contacted my friend in Nice, and then it was also very easy.
Yeah.
So, but I think if you have a young doctor who wants to do the TAVI, he needs already to have some good skills with PCI. You cannot just, you have to respect the steps. So you first have to be comfortable with handling, usual coronary complications. Otherwise, you cannot just start TAVI. You need to be PCI.
Yeah, you also, your
Because-
answer also is my question.
Mm.
Can I start with the young interventionist? But actually, it's just not familiar with.
You need, because
Yeah.
the first thing is you need to learn how to puncture and how to do the closing. So the pre-closing with the ProGlide, with the 2-wire, you need to practice. It's you need to practice. It takes time. It takes time.
Because the young doctor is too young and the old doctor is too old. So it had to wait. So it means I had to wait 2 or 3 years. Actually, I don't want. But if I send the young doctor, I think it's too young. And all is too old. I don't want. Because after he studied and when he turned back, maybe he retired.
But if you take a more senior doctor, if he can still practice like 5 years, then you have time limit that he transmits the knowledge to the younger.
Yeah.
It's possible.
Mm-hmm.
Possible. Let me show you this case.
Okay.
This case is a dramatic case. So I do quite a lot of CTO, and every now and then I invite somebody to work together. I think we're quite comfortable, but on this occasion I had a very famous Japanese doctor who I know very. I will not tell his name because it's a bit delicate, but everybody know him.
Yeah.
And he's a really nice guy. I like him a lot. He's and
Ochai.
No, I will not. No, not him. I don't like Ochai. I will never invite Ochai. This doctor is much more gentle, nice. So this patient, you see, he has congenital deafness. It's very important to notice. So the communication is very difficult, and this was during the COVID period, still last year, I think. So we have the mask. He cannot understand. He cannot see the mouth moving.
Mm-hmm.
Then there is something wrong. Yeah. He has a severe angina. He has a CT of the right, and they already tried 2 times in different hospitals, and it was last year. And so we do this case. So he come from Sion. So it doesn't look that complicated. You have the CTO. We have 2 times 7 French in place, 1 radial, 1 femoral, and you see that the procedure is going quite smooth. But I think to be short, I think we lost several times the access. Several times we were able to get distal, but then we lost the wires. I think he also flew overnight, and he still had some jet lag. And I really don't know. Basically, it was not my patient. There was one senior doctor was doing the case with the invited, and then they had some trouble, and then I scooped in also to help them. And you see we have the 2 wires parallel here. We have the wire exchange. The wire go retrograde into the guide extension, and then you block it, the wire with a trapping, and then you advance the microcatheter, and then you do exchange with the 3-meter wire. You know that technique with the wires. Okay. So then the wire is lost. It has to start from the beginning again, and then the wire is even subintimal. A lot of complications. You see, really complicated. And then the major problem is here.
Aortic.
No, not yet. No, it's not aortic dissection. So what basically happened is that after I don't know how many hours of work, I think not how many hours, we are okay, but the lesion cannot be dilated. So it is impossible to dilate because the CTO is here, the CTO is here, CTO is here, here, but on a mouth of the CTO is this undilatable lesion. So this lesion is very calcified. Very calcified, yes. So the decision at that moment is to use a rotablator. But of course you have to get the rotor wire through. I'll show you. You see how much time the whole thing took? Look here, this. You see the time? This is the report, the final report is all the material. Yeah. And this is the rotor wire, yeah? At a certain moment, okay? Okay, so what was done? I'll show you again. I'll show you again. So what was done is to get a microcatheter all the way through, and then the doctor, the famous Japanese doctor, decided to get the rotor wire through the microcatheter. Okay, so the rotor wire is a long wire, and the rotor wire entered, I think, radial and came out femoral. Okay, but the sewer wire is very soft, and the rotor wire is also soft, but different. And what happens is, so the rotor wire is in place. We are ready to do the rotablation, and then the invited doctor, he pulls quite quickly on the microcatheter to pull it out from the LED, to pull it out a bit. And at the moment he pulls out pulls back the microcatheter, the patient arrests. Oh, stop. At the moment he pulls out the microcatheter, the patient go into extreme bradycardia and then flatline. Flatline. So what to do? Resuscitation, of course. So at that moment also, my senior colleague and the Japanese doctor also, they were totally frozen. They didn't move anymore, you know, they were like, ugh. And then I say to the team, call the cardiac alarm. So call in, they come in, intubate the patient. Also the problem is that the patient was quite comfortable for all these hours, and we give him some, you know, like fentanyl, like a previous patient, to calm down. But the communication was impossible because he cannot. Imagine he cannot hear and he cannot speak. He doesn't know anything what's going on. So this probably played a role. So we do the cardiac massage, we intubate, but the patient quickly asks for a bedside echo. Like we did also, do a bedside echo, the heart is completely blocked, it doesn't move anymore. Like this, not moving. So what to do? We need to see what's going on, we need to do something. And how can we manage the patient? We want to check the angio, we want to see how it's a coronary. But on the other side, we want to do massage. So how do we do that? Do we have some solution for that?
You just stop
Jet
for
compression. Automatic jet compression.
Yes. So I called to have the Lucas. You know this Lucas machine? So I did a few cases like this with Lucas. So we put the patient on Lucas, and we inject the coronary.
okay.
So what do you think?
Maybe some perforation.
So the LED is open, but what do you see? The heart. What do you think? When you look at this image, what do you think? So I show you before this picture.
Yes.
Okay.
Yeah.
This patient.
Tamponade.
Yeah, it's good to think about tamponade, yeah. But I don't think so. No, this is the Lucas that is working. The Lucas is working, but if you look at this, there is no heart activity. The heart, we did also an echo, the heart is completely not moving at all.
Yeah.
And look, this is after a while. What do you see?
Receptor primes supply to an actual system HRE as well.
Yeah, that may be a point, yeah. We will come to that later, but first of all, where is Lucas now? Where is Lucas?
Do you think because the heart is moving?
Yes, you're correct. So just look what we see. First of all, the heart is moving again.
Yeah.
So everybody happy? The patient, the heart is moving again. So we can take out the glucose, the heart is moving again, the patient has blood pressure again, so everybody's happy. Okay? So what is vital thing to do in this kind of patients? So the patient get intubated, we do the cardiac resuscitation, and we have of course the intensive care guy who's taking care of the patient together with us. But what is vital? What is the concern we have in this patient?
So you have some dissection already.
No, I think it's full spasm because of the inotropes, the spasm. And the patient has diffuse disease. Huh? We will come to that later on afterwards. But what is I've seen it already quite sometimes. What is crucial in this kind of patient that you resuscitate? What is crucial? There is something that the heart doesn't like at all. You know, let me start simply. So when you have a cardiac arrest, you know, you have anoxia and you have, you know, irreversible, you know, damage to the vital organs. Okay, everybody agrees. So what is a marker of anoxia? Yes, okay, perfect. So the first thing to do, and I always draw the blood gas all the time. So, and when I see the lactate sky high, then I'm really concerned. Because why do you think so? So I'll explain you. When this happens, everybody was very happy, but I was very concerned. I said we are going to lose the patient because this patient get in the vicious circle of, you know, of metabolic lactate acidosis, metabolic acidosis, lactate, and the lactate is just terrible. You know, the myocardium is impregnated with catecholamines that you have given, and if the patient in a very bad metabolic state is acid and with high lactates, it's very difficult to recover these patients. So what happened in this patient, after like 20 minutes, the patient crashed again. And what to do? What can we do? He's 70, he's not so old, yeah? So mechanical support. So in this patient, that would be ECMO, yeah? ECMO. So this was 1 year ago. There was still some COVID. So we called the intensive care, and the chief of intensive care say he's too old. He's too old, and we let the patient go.
Oh.
So he was 70. He was not 80. So after like 20 minutes, the patient went into shock, and we didn't even put the Lucas on anymore. So we let the patient pass away.
So what is the mechanism of cardiac arrest?
Okay. Okay, so first thing, I heard some people say tamponade. Huh? So I can see when I see this image of the heart, I say this patient has no tamponade. Why do we say this?
Only one ball.
Yeah, because if the patient is in tamponade, we have what we call the dead heart syndrome. So you see this is the left ventricle, it's moving, yeah? If you have a tamponade, you often have like a halo around the heart, and you see like what we call the dead heart sign. The shadow of the heart is not moving. Here, you can see. So if you have in the cath lab some problem, and you have the patient in shock, and you suspect tamponade, just push fluoro and look at the heart. If you see the heart shadow with an image of that heart, that the contour, the shadow of the heart is not moving, and you see a double halo, and the patient is tachycardia, he has paradoxal choices, just drain. If you don't have echo machine, it's the middle of the night, just put the drain. Okay? Just put the drain, nothing more. Okay? So why did this patient pass away? That's the question, huh? Oh, I show you the message of the doctor. And you see, he was very, we didn't meet again since then, but I sent him WhatsApp, and he was very nice to see. For my, I didn't do many teaching, you know, I don't. But you can say he was, he felt very, very, very bad, very, very bad. What's up? So now the question is, why did the patient go into cardiac arrest?
Immediately before that, use we got the insert the rota Y to the left and go via the contra, the collateral.
I think this was a major mistake. Yeah. Because
and some spasm of the whole system.
Yeah. So what the problem is with the RG3 is a very soft wire. The RG3 that is used for
RG3.
Yeah, it's a very soft wire, 3 meter long. The rota wire is not made to make a arterial loop. And you know what happens is, if you do this kind of CTO retrograde with RG3 wire, if you pull on the RG3 wire, that means you pull on the vasculature, the patient will have a vasovagal reaction, and the pressure will go down. You can see that. Any intervention you do, also for structural, for example, when I sometimes make loop to close the VSD after acute MI, if you pull the heart on the wires, you will stretch the vessel in the heart, and the heart will
You look at máu là
Yeah.
tim vậy đó.
It will provoke an extreme vasovagal reaction.
Separate the vessel from the heart.
Yeah. So what happened is, when he pulled out very quickly, there was an extreme vasovagal reaction with asystole, and the patient did not support this. He went into hypotension. Hypotension. He has some. If you look, he has some. Look there. He has some. If you look at the angio. He has some disease on the LED, and he has some disease on the. You see, he has some disease here. He has some mild three-vessel disease. So I think he probably got into global ischemia, hypertension, global ischemia, and over and out. Immediately the heart arrested. He got into metabolic, circuit of metabolic acidosis, lactate going up, and then you lose the patient.
Don't you think that if we continue to resuscitate this patient with ECMO, we can survive?
Maybe I showed it already last time, because I had a similar patient. Didn't I show this one already? I showed this one last time. With the same, when we had an occlusion of the left main. I think I showed it to you already. But I had the same problem with. I think I showed this one.
Yeah.
Where I had this patient with the occlusion of the Yeah, I showed it already. But I want maybe to show the complication I had last week. If I can get back to my... I just need to see if I can get onto it. I will show you that. I just hope I can... Yeah, this one, I'm treating this patient. I'm trying to go on... What's this? I'm trying to go on the software of the... I just hope it will work, on Philips. Philips IntelliSpace, okay. So this is the yes. This is the all the echo of the hospital are on this server. I just hope it will work. It's just a bit slow, I hope. Yes. I'm not really used to this stuff, but trying to. Okay. I just have to check the name of the patient. So this was last week. Yeah. Okay. Okay, I need to. I know I need to put the day. I need to put. I'm not used to this because this is for today, you know. Because this is all the examination of the today. Oh, here it is. Yeah. The last 30 days. Okay, let's see. Okay. You will see something I never seen before neither. If it works.
Ý mình mời cô con Christina. Try.
Okay. Alright, Christina.
Or something like okay. Đây là có nhãn lon ngang, lon gạch, lon ngang, tôi đi kéo lon ngang, lon gạch.
Okay, I try it.
Mời bằng lon ngang. Yeah.
Oh,
Lon gạch.
it should work now.
Sure.
I try to see if I can do it. I don't
Rồi,
use
uống
this.
sữa là phải có. Uống sữa là phải lấy cái dao cắt, dao cắt cái dĩa rồi lên. Mày để cho mày rất tiền lấy thêm một cái dĩa nữa rồi cái dĩa hoặc là để đang lấy cái đai này, lấy cái khăn đó. Rồi. Cái dao này ra. Em đưa dao cho cắt lại để lấy thêm một cái mũ. Đó là không nè, mày chuyển dưới rồi mày hỏi bác ăn không, mày chỉ đó cách ăn mà biết ở đám bên tụi Singapore nó có trái này không chắc không đó.
Okay.
In Vietnam, we call it vú sữa. In English, we call star apple. Star of the sky. Star of the sky. Star apple. Yeah, partially. In Vietnam,
I don't know this.
Rest of the females. In Vietnam, yeah. In Vietnam, we call Wu is the rest of the communication.
Yeah, it's a range. I think it's an echo. But I'm trying to.
This name called
So that's the name of the patient, and then I say the last 30 days.
cái mũ này, cái mũ
The last.
Or maybe longer.
No. Maybe because here is
cái mũ cái em đưa cái mũ em lấy một cái gì đó
because normally I manage to do so, but I don't take the points because it,
it's yours. Yeah, this one is yours.
if I put it here, I don't know why I don't get it. Because it's the last 30 days and he didn't give it to me. Yeah, I know, but because it's this complication has never been described, and it's only echo images. It's no angio. Yeah, that's what I want to share to you.
Các bên trên đó. Yeah. It's good. Chứ Long An nhiều anh nó cái có Long An các.
What about that? I think I'm doing stupid things.
Để ông mở trực tiếp cái này.
Okay.
Rồi cái hệ thống mắt của mình á, nó không có mở, chủ yếu là mình đi vòng vòng Việt Nam thì mở có được, mà đi quốc tế là tại vì tiền không có mở theo cái mạng này chứ. Bạn trong cái hội mà set up ở đây nè, họ phải set up họ hỏi này mình có mở không, nhà quốc tế hay không, Việt Nam, nước ngoài, như mình mở ví dụ mình qua nước ngoài mình mở cả, chứ là nó khóa.
Sure.
Chứ còn chỉ cần đổi cái qua nước ngoài coi.
Short on TV. Okay, and we'll see the last 10 days. So we have, I think there are maybe more than 50 echoes every day, so I think I can't get it in.
The last 10 days.
Yeah, because it was last week. I'm sorry, honestly,
Can you list out all the cases?
yeah, that's what I'm trying to do, but because here this is the cases of today. But this is only today. This is only today, all the echo in our hospital. Only for today. That's a lot. Maybe. Sure, 2. I can try 7 last days. It doesn't want, it's too much that the server doesn't. I was done last week. Here, maybe. Let's see if this works. Normally, honestly, I don't think I will manage to do so. Because it's here that I have to put it. Otherwise, I have to call a colleague to ask him. Maybe I'll call a colleague. I just call a colleague if he can help me. Ioannis, oui, bonjour. Je vous dérange. Ioannis, je suis entouré d'une dizaine de docteurs de Vietnam à Ho Chi Minh. Puis j'essaye de montrer M. Saillant à mes collègues. Je suis sur IntelliSpace de Philips, mais comment je fais pour. J'arrive pas à aller dessus. Donc. Sur IntelliSpace, oui, je suis dessus. Et puis. Liste de travail, oui, je vois ça, oui, liste de travail, oui. Comment je fais pour arriver? Attendez, hein. Oh là là, qu'est-ce que j'ai fait maintenant? J'ai fait quelque chose de fou. Liste des examens du jour, ok. Il n'y a pas de X chez moi. Attendez, je pense que je vais juste raccrocher, je vais juste fermer l'application et puis je vais l'ouvrir. Ah, ok, je vous rappelle, hein. Ok, petit moment, merci. I will call him in video and he will help me. Because I really want to see this Philips. Okay. The only thing is, it's a bit, because it's a bit slow. Okay. Okay, I'll call him. I will turn it on. Voilà, Ioannis. Voilà, attendez, je vais tourner l'écran.
Ouais.
Voilà.
Donc, à droite.
Oui.
Là, vous cliquez dans les croix aujourd'hui.
Ok. Oui.
Et maintenant, vous cliquez à droite le nom précédent, ça y est.
Ok, attendez, je mets un peu plus fort. À droite, le nom et le prénom, oui.
Le droit, c'est des noms et prénoms.
Oui, Sayen Pierre, oui. Ok, j'ai fait.
Seulement ça. Écris ça y est. Seulement ça y est.
Ok. Sayen. Ok. Yes. Ok, j'ai mis. Ok.
Montrez-moi, je regarde. Je vois pas.
Oui.
Oui, cliquez Enter.
Enter.
Ouais.
Enter sur mon ordi.
Ouais.
Excusez-moi. Il dit rien. Attendez, hein.
Pourquoi? Parce que je ne vois pas tout l'écran.
Oui.
Encore un peu de droite.
Oui.
Là. Cliquez sur le Sayen. Cliquez sur. Ah, non.
Ok. Et Enter, oui.
Maintenant.
Ah, ok, je l'ai. Je l'ai. Magnifique.
C'est 22 du 1er à 8. Ah, non, pardon. C'était les bons examens.
Celui de vous, là, la nuit.
Les 16 avant le 57.
Comment je vois ça? Ok.
Avant le 57.
Ok. 16.
Avant le 57.
Yes. Ok, super. Merci, Ioannis.
Ok,
Je vais y aller. Merci. Au revoir. Ok. Thank you. Okay. So, finally, this guy is 70 plus, and he has a pericardial effusion since more than 1 year. Since 1 year he has a pericardial effusion, and and the patient has a obstructive lung disease. He doesn't look very fit.
What about the cause of the
Yes.
pericardial?
So the effusion is already known since 1 year. And the cardiologist is contacting me, can you just train this to do a diagnostic puncture to know what's going on? So the last time he sent the patient to me was a few months ago. I drained, there was like a yellowish liquid, I drained. I leave the drain for one night and it comes back, he has a lymphoma.
Lymphoma.
So, you know, so I do the drain. So how do you, what is your practice for pericardial drain? How do you mostly do it? You can do transapical or you go here. Yeah.
Substernal.
Substernal, yeah.
Mặt phẳng như giờ là phòa.
Substernal.
Cái đường dưới này gọi là giờ là phòa.
So I do it in the cath lab because it's elective. So the most important is to, after the local anesthesia, is really to puncture horizontal. People, the complications occur when people puncture too tangential. You can go in the liver, you can go in the right ventricle, you can puncture the right coronary, you can puncture the left coronary when you do transapical. You can have all kinds of complications. You can have a lot of complications.
So you prefer
I do this, and then you really.
So
I puncture, and my wire is going up. It's not going like this around the apex. I find it very strange, and it is blood. It is blood. Blood is coming out. So I repuncture a second time. I'm not really sure. I repuncture a second time, and I see this time my wire is making the bend to the apex, so I say it's okay. I do dilate the skin, I dilate the pericardium, I put the drain, and I put on negative pressure, and there is maybe 100, 200 cc of blood. I move the drain a bit, and I have more blood, and I do this under echo, I repeat the echo. The patient say he has more, he feels better. So he has some pericardial pain also, he said, he's straight, he has more pain. So everything is compatible with that I'm in the pericardium. I do a blood gas, I mostly also do a blood gas. Hemoglobin is 3. So this is not, I'm not in a cavity. And I have to mobilize 3 times the drain, because when I do the echo, there is a lot of adherence and some, fibrin inside the pericardium. And finally, I stop. There is almost no more pericardial effusion. I send the patient to the ward, and that's it. And then, look at this. I think you've never seen this before. You see, I'm not used to this program. Here, yes, here.
Dạ, hay ở ngoài mà.
Okay. Finally, what should be? Should work. I have to do it 2 times. Okay. Okay. So what do we see here? I have never seen this, huh? In the beginning, I didn't know what I was seeing. Huh? I go down a little bit. So this is, there seems to be, this is the, I'll show you further on. Yeah, here, yeah. Yes, we have it. What is this? What is this? It's very scary. It was in the night. The doctor called me last week when he saw this.
Why go-
This doctor, the doctor I just talked to.
We're going to go from liver to our right ventricle into septum.
So what is this structure over there? What is this? What is this? What is this?
Right ventricle.
Right ventricle, yes,
with
correct.
something stuck on it.
Where is the right ventricle? So this is the left ventricle, this is the right ventricle. But what is this then? What is this?
Maybe some blood or something that's from on the right on the ventricle.
So this is echo, it's not cath lab, huh? Yes, good. So I show you on WhatsApp the doctor. So Ioannis, the doctor, he called me last week. He called me and he sent me, this was in the night, it was like in the middle of the night, he called me and he sent this to me. So this here, see? So for me, I say this intramural hematoma of the right ventricle free wall. So everybody panic what to do. So I was in my bed and I said it's a hematoma, but it's not bleeding, and the drain is only given 40 cc in 1 hour. So that's okay. So what I do, I just in my bed I go on PubMed. Okay? I go on PubMed and I find this article. Okay? Complete recovery of right ventricle from intramural carcinoma hematoma complication of PCI.
Do nothing.
Yeah. So
Do not
yeah,
think.
no. So then the patient said, the surgeon say, okay, I operate. I say, no, don't
No,
touch the
do
patient.
nothing.
Do nothing.
Do nothing.
Then the intensive care people say, I take the patient in my, no, the patient stay with me in my ward. And then I say, everybody panic. And I say, no, the patient doesn't move. Don't move the patient.
Yeah.
Just be,
Everybody
what
panic.
will you do? What are you going to do? What can you do?
Nothing.
You cannot do anything. So I just quickly look and so this kind of, that's what they write, it like mimics like tamponade because the filling of the right ventricle is not well. So it has been described after PCI, it has been described after surgery, and has been described after trauma. Has never been described after pericardial drain. So this is a world premiere, it's never been described. And then I have the second case.
But how can it form the after growth?
So how does it come?
Yeah.
So this is another case. So right ventricle secondary to PCI. Look at this one. Look at this one. Look. The image. This is even bigger than mine. You see this one? This is a bigger one. So I will ask this young doctor. He will write a case report, but it has not been described, and the treatment is normally conservative, if you can. Yeah? So we follow the patient. I hope that I don't lose, because I'm going to show you what happened. Yeah, the other. How do I see the other images? Maybe I just hope. Yeah, this is the day after. I'm not really used to. I'm not really used to do this. But within, okay, within 3 days, it completely disappeared. It became flat again within 3 days. I show you. What do you see here? This is a few days later. This is 1 day later. You see this here? So basically what happens, so why did this happen, you think? This complication. There is some cavity, there is a blood cavity in the wall, you see? There is a small lake of blood in the wall. So what I think happened, the patient had some adherence, and the tip of the pigtail, the tip of the pigtail of the drain is quite stiff, and when I moved it, probably it lacerated the wall of the right ventricle, and the patient started to bleed inside. And then I put a drain, but I put a drain with too much negative pressure. And because of that, I created, a permanent. It drained out 1 milliliter of blood, and then the surgeon they changed the drain to a surgical drain that drains not so strong, and within a few days, the septum became completely like before.
But Victor is the side of the Victor 4 French.
Hmm?
The side of the
He's 8 French.
Eight French.
He's always 8 French, yeah.
8 French.
So
big.
yeah, he's look here. It's already much better. Yeah?
Bự vậy chứ còn mình xài cái chút xíu đâu dễ biết vô thì
It's always 8 French.
8 French.
I think so, yeah.
We even use only the 4 French. 4 French, the pigtail, in case of the feminine.
Yeah, but we have a dedicated set from Cook. They make a dedicated set for that. I'm sorry it takes some time, but I think it's very spectacular. Because my computer doesn't match. But anyway, you see, it's much better now. You see, I'm sorry that can I do better? Yeah. Interesting case, yeah. Yeah, here it's much better now. And this is only after 2 days. Yeah. Yeah. Finally. You see, it's much better now. And you see this.
Ai xin kêu á là bây giờ xin cái giấy xác nhận làm việc tại ca ký hả?
Không. Mai ký.
So this is my complication from last week. Funny, huh? And you see this is probably here. I created a small laceration with my tip of my pigtail, and this is the crazy. Yeah? So this is a quite unique case. Yeah? Okay. I'm happy that finally I was able to show it.
I
to you.
just remember the 1 year ago we received one case from the other hospital transferred to our hospital because the patient also had a pericardial effusion and they did the French and they also the puncture with the purpose of diagnosis only. At the time they insure because they use the sheet. Yeah, they insert the sheet first. Or maybe they use the femoral sheet.
Oh.
Femoral sheet. 5 French or 6 French. 6 French.
Yeah.
But at first they set up they reject the position of the guy wide, the guy side also the round shape, a round shape. But I don't know what happened when and then they for the confirmation they inject the sheet French. But it's oh my god, the sheet across the LV. Right, the right level, and the tip of the catheter that across to the septum, and now the tip of catheter in the left ventricle, across this. So, but the patient has this stable when the patient. When they transfer in our hospital, the hemodynamic is stable. So I think that, and also have at the time that they know the pericardial effusion. It's just only the 10, just around 10 millimeters. So not too much. So it's slightly difficult to do the puncture and activate again. So nobody want to have the two options. One is from the cardiac surgeon. Oh, do nothing. Yeah, do nothing. Let's tomorrow.
Okay.
But actually, because the tip of the femoral sheath, and now it's touched the septum and in the LV, and when the stem swinging in and out, now we see we see the VT, we see the VT, short VT,
Okay.
short VT, short VT. So I think that it's the unstable situation. Even though have a very just only the small amount in the fluid in the color, so we cannot puncture it. So I think it's not a good decision, but I have no choice. I withdraw. And so after we close the ship out, also had the now, because I now the horn of the horn of the ship in the myocardium.
6 French.
Yes, 6 French. And the patient is immediately developed the tenderness.
Oh.
Yeah. So, but now it's easier because I had the
Now you have
I put in the pericardial infection and put it up.
Okay.
And also because now I take a lot of blood, but it for sure that the pleural and parietal of that close together. So and I hope that is had the natural hemostatic.
Okay.
Yes. So I think like this. Oh, I win.
Okay.
Yeah, that's okay.
Fantastic. And it
Yeah,
Wow.
yeah,
You
and
should
also,
present this.
but actually, I also still in the. I also insert the detail, and we also still be there until because I'm afraid that the recurrent.
Of course, you need to leave the picture
Yeah.
overnight.
Yeah, and
At least
also
24
that I
hours.
had to discuss with the cardiac surgeon. Oh, you did well. So step more like again like this, and so the next day, the 7th day, that is okay.
That's good.
That's it.
I
have no choice.
I think 2-3 years ago, a colleague of mine, I think there was not many people in the cath lab, and we were busy in the 2 lab, and a colleague of mine has to, a girl, she's 30 years old, she has a Crest syndrome, Crest syndrome, Crest syndrome. Crest is a sclerodermie.
Cái gì?
Crest. No, Crest. C-R-E-S-T. Crest syndrome.
Crest là cái màu.
Cái màu. C-R-E-S-T.
I said it.
Crest đúng là màu. Crest syndrome.
Syndrome, yeah. He's our patient. Yes, I accept. Crest syndrome is Crest syndrome English. Yeah, you know this. So these patients they mostly have pulmonary hypertension. And so the young patient, 30 years old, with Crest syndrome, they do a bronchoscopy, the pneumologist, and all of a sudden she has tamponade. And my colleague in the other room, Vladimir. He was here last year. Vladimir.
Mm-hmm.
Yeah, the doctor from Rwanda. You remember?
Yeah, I remember.
He do the drain in the other room.
The last year you Vladimir and Julian, right?
Yeah. So Vladimir, he put the drain,
Mm-hmm.
and I'm doing a STEMI, and then I go and see, and he said it's all going well, and he said there's a lot of blood coming out, a lot of blood, and so it's 8 French, yeah. A lot of
8
blood.
French.
Yeah, in the we have the kit. The kit is a kit by Cook. Everything is inside. The needle, the drain, everything is in a kit for pericardicentesis that we use. So and it's bleeding, and he inject a little bit of contrast. He's in the right ventricle.
Yeah.
In the right ventricle, like you.
Yeah.
So and then the surgeon come, and then I was in the cath lab, and then the surgeon come, and they want to send the patient for surgery.
Yeah.
And I say, and I come back and I say, you don't send the patient. She has pulmonary hypertension. The outcome will be very bad. And then I say to Vladimir, you know what I said? We will put angioseal. Because I have seen,
you
I've seen at my complication course in Lausanne, some doctor from Bulgaria present the case and he put angioseal.
wow.
So I said to Vladimir, we put angioseal 8 French. And we put angioseal.
Where you put the angioseal?
So you just put the wire through the drain. You pull out the drain, and then you push the angioseal inside the right ventricle, and then you see the blood coming. Okay, and then you just keep and then put the angioseal, and then slowly and perfect.
Wow.
But we never published.
Yeah, off label. Off label intervention, but actually that is success. Yeah.
So you see, it can work. Huh? Yeah.
Đúng rồi, đang nãy những bữa vậy là mình đút cái quai vô, xong mình đút angio siêu vô, cái mình rút này ra, mình giật cái bạc, cái mình khóa lại cái chỗ đó. Đó cũng là option.
Cái dù vậy đó.
Đúng rồi, nếu mà những cái dù đó cũng là option đó, mình làm cái đó. Không,
nó động tại chỗ luôn.
Nó động tại chỗ hay
nó
là
thả vô là động.
tại cái loại angio siêu.
I told you this is so for example this is the
This case.
No, I show you because you wanted to know about this. So this is for the big sheet. No, this patient this is the old version of the ProLite.
ProLite.
Do the 2 ProLite 10 o'clock and they make a mistake there. You see? So you see how we close. This is the ProLite.
Năm nay mình mua mấy trăm cái á, cho nên là if you want to do TAVI, you have to start with the,
you have to learn this.
closest
You
device.
have to learn. This, it will start again normally. It will start again. This is TAVI case.
Nhớ bên tụi gì đó, thằng gì mà
basically they make a mistake here. They make a mistake. I show you the mistake. So what we always do, this is a wire. We always leave a safety wire inside the patient, because if the ProGlide is not closing well, you can always put angioseal on top. You see, and sometimes we have to do that. But here, look, they put the wire. It was not my case. Look carefully. They put the wire by accident. Look now. Look. You have to leave it in, and then they pull it out. Look. No, they pull it out. They make a mistake. Never do this, yeah. You have to leave it in, yeah. And you see the suture is there. This is the old.
Bữa vừa rồi thằng Quy mà nó Quy làm mới ca thứ 2 đó là xong rồi nó khâu luôn 2 cái động mạch đùi hai bên đó, thấy không? Nó dứt xích rồi 2 động mạch đùi bên kỳ ca bên mà bên tụi nó bị ấy đó.
Okay. What else can I show? I don't want. This is MitraClip, and I want to show you. We have maybe I don't have it here. Let me see if I have it. I will show you something
Nó
really.
điên đâu rồi? Chứ làm từ từ đi, không? Đáng lẽ nếu mà Sơn tính toán ấy là
Nó
giờ
cả
này
cái quản này, cái quản mày làm.
giờ này là nó yên, nó xong xuôi hết, mọi người về rồi còn tính toán ngu si, giờ này mỗi người còn ngồi đây không làm được ca.
This is a question for you. What is this? This is 3D echo, yeah. This 3D echo.
Ủa về nãy kêu Hậu làm cho rồi, kêu Hậu làm.
So let's start with the. What is this?
Cái quản này lúc 4 mấy.
What is this? Aortic valve, yeah. What is this? This is the interatrial septum, okay? This is the posterior, aorta always anterior, posterior wall. Here should be the left atrial appendix. So what is this thing?
Cái van tạo. Van
How many leaflets we see?
paralytic.
How many leaflets we see? How many? 3. So and which valve? Which valve should this be?
Sợi nó giống như nó bắt ra vậy đó.
It can only be. It can only be
It's the nature, right? Or
Yeah. In
Okay.
this valve normally only has 2 leaflets, so there is something strange there.
Văn là chủ hay mạnh. À. Nãy nó Văn đồng chủ mà đúng không? Không phải.
So there is something strange there, yeah.
tại vì mình không có nhìn qua cái hình.
So it should be the mitral, but the mitral has 2 leaflets, and this one has 3. I'll show you more.
Quan đồng chủ,
Văn đồng hay lá mà Văn mạnh.
So this is on the right you have the LVOT view, and there is a valve in mitral position. Okay. So I can tell you it's not a surgical valve. It's not a surgical. No. Mitral clip is this is a new mitral valve. It's a percutaneous. This is the tendine. I show you. We have done 3 cases of tendine. Tendine is a percutaneous mitral valve. You put through transapical, okay? And the valve is maintained by a wire. You see this here? At the apex. This is the only valve that is commercially available. Percutaneous mitral valve is a tendine, and we have done 3 cases. But, this is certainly not the future of the mitral, but I show you this because you will not see that very often. So this is for the moment. Tendine. This is tendine valve, okay? This is the valve you see. You see, do you wish to continue? Okay. So this is the valve, this is the cable, and this is on the apex of the heart, outside the heart, to keep the valve in place. But this is, I don't think this valve has a big future. But for the moment, it's the only commercially available. Looks horrible.
Wow.
Looks horrible.
How about with your left?
We have done 3 patients.
3 patients?
Yeah, the 3 patients we have done. 3.
Uh-huh.
The case I showed you was one of the patients.
But actually, how about the results?
Not many data. So
Your result, you said your result after that.
the future of the mitral is the true percutaneous through the transeptal, not transapical, of course. Yeah. But 5 years, maybe more, you will have to wait. Yeah. I think I don't have much more. I can continue for hours, but I think I've showed you most of the things that I wanted to show. Maybe this is interesting. Yeah. One case to finish. This one. Primary PCI, STEMI. The patient is let me see. He's maybe 51, 52. 51, 52. Not so old. 51, 52 years old.
Là bao nhiêu tuổi? 54 tuổi.
So what do we make out of this? Severe chest pain, very not comfortable. He feels it's STEMI, but where is the STEMI? Which vessel? It's difficult, huh?
No, it's arterial MI and also had the.
No, this one is the lateral.
No.
It's a really difficult case. It's a really rare.
Actually, you see on the before and before, you also see
Yeah.
the SD elevate the primary.
Maybe
elevate.
mid LAD or something.
And even though you see the RBDP, RIP in the1, so with the
But there is one major thing because we always get the teaching from the electrophysiology guys. There is one thing. The first thing we have to look for on the ECG is what do we have? The first thing before we look at the ST segment. Yes, you win a lot of points today. So it's not sinus rhythm. Yeah, it's not sinus rhythm.
no sign of in the VR, AVR.
I think there's something here. There's something here. There's something here. He's not in sinus rhythm. It's a kind of nodal rhythm which is compatible. It's like 60. He's probably nodal escape, and it's probably in AV blocker. Okay, that's already not good. Huh? That's not good. And I agree with you. When we have imagine we have an anterior MI. We have almost right bundle branch block. Okay, you agree? Yeah. Okay. So when we have right bundle branch block in anterior MI, what does that mean?
Before the center.
Yes, because the septum in 80% of cases is perfused by the first septum will perfuse the right bundle. So this would mean that we have a very proximal LED occlusion.
That fascicular block.
Yeah, but then we have this.
Fascicular.
Yeah, this ST
Độc đâu qua trái, block
elevation.
trước, cộng block bên là block 2 thôi nhé.
So if you look at this, this is looks like inferior MI. It's very strange, no?
Thực ra nó không phải, nó do nó bị nhìn cái điện tim này nè, nó
You want to see the angio?
trục qua trái.
Yes. I want to see the angio. Okay. No.
Cái này có đại.
Không, tắt em đi. Không, tắt một tờ xe.
So for me, it's very easy to criticize. I came in a little bit later when they were doing the case on a Monday morning or Monday, I don't know. It's a Monday. And I see the first mistake. Yeah. But
Người mới. Cái gì mình sẽ mở theo đi. Tại vì nó vừa có block nhanh.
there's already one thing you can see, as you mentioned before. If you see the movement of the circumflex, this is not sinus rhythm. You see, the should not.
Là
It's
nó ra
not.
trước.
You see. So what do you think? What do you think about the LED?
Well, I think it's the LV equipation because we see the anterior fascicular block and RBD block is the two high dynamic block. Yeah, and also we see the ST elevate in the V1 to V4. So and also with block left fascicular block and RBD block. So I suppose that the equipation is proximal LAD. Because it affects the dẫn truyền transmission.
Yeah.
So I will open LID instead of the RCA.
Absolutely, I agree. So the thing is also look at the. We don't need echo, but we can see on the injection that the LV function is very bad. You see, it's almost moving.
Yeah. Definitely, because we occluded LD
So,
and RCA.
so when I arrived, the doctor already. What is the other? There are so many reasons not to open the right. There are so many reasons. Where what can?
Không có mở bên phải.
What can be the reason not to open the right first? There are so many. We can say we have many reasons. What do you think?
The first A I told you that because we only open the combination first. The second is the
So this the lady doctor thought that it was inferior MI. It was the culprit. So she wanted to open the right first.
No.
But why would we not open the right first? For what are the reasons not to do so? There are many. Yeah?
cái điểm tim mà nó giống như máu phải bên phải là tại vì nó bị gốc phân nhánh trái trước cho nên nó mơ đó nó cộng
If
với
this
phải
happens
nó
to
ra
you-
để nó block hai phân nhánh. Thấy không?
First of all, the first reason is the myocardial matrix is much larger in the LED.
Yeah.
The anterior wall is much bigger than the
60%
inferior.
of the
Much
LV.
more.
Yeah.
Reason number one.
Yeah.
Reason number two, and maybe more important reason, what happens sometimes when you do primary PCI in inferior MI? What happens? When you open the RCA, what happens sometimes?
Block. Block.
So they have bradycardia and
Yeah.
sometimes VF,
Yeah.
VTVF, and sometimes hypotension
Yeah.
because of the ventricular reaction when you open the right. So the major reason not to open the right first is if this patient secondary, imagine that the right is also thrombotic and the patient has a bradycardia hypotension because of opening of the right, then you're in big trouble because 2 of the 3 vessels are blocked and the circ is not big.
Yeah.
Then you go crash into the wall. Okay? So she opened the right and the patient immediately hypotension, bradycardia, flatline. Over.
I think ABB first. ABB first.
No, well, when I saw this happening, they resuscitate the patient, and then I arrived. At that moment, I arrived, and I said, at this moment, call in the intensive care, and I told them intubate the patient as soon as possible. But they, I don't know why, nothing worked well. They didn't intubate him on time. Finally, they intubate him, and then I said, so in this cascade, you can put impella, we have impella, but if you put impella, you don't have much time. You have to be really quick because at the moment when if the patient is in too profound shock, the impella will not work. Then you have only ECMO. Okay. So I'll show you.
We use the impella slide.
Now we have the impella ICP. So this is after open the right, you see. Everything stopped. Everything stopped. And once again, I told them the only thing you can use is the
Machine.
is the
Cái máy
is
hay
Lucas.
something. Hay something.
So at that stage, the surgeon came in. They put in the ECMO. Then the surgeon had a vascular complication. He damaged. Before the ECMO was in, it took so much time. It was horrible. And this is after. So what I write here. So the patient had a bleeding, had a pulmonary infection, kidney dialysis. So I think here everything was wrong. Look at the LV now. The patient survived, and he is on the transplant list. I don't know if he's been planted. So yeah. So the whole anterior wall is gone.
You open the LD and
They opened the LED.
LD and
Yeah.
RCA. Yeah.
They opened the LED under ECMO.
Open LD, RCA, impella.
But
and
they put a stent under ECMO. See
Yeah.
here?
ECMO and
Yeah.
after that.
But so I think this case shows you a wrong strategy, wrong decision.
So I also told to my colleague that is the very important role of the ECG. Yeah. So ECG also give us something we never think before.
If you see this here, this is thrombus. This cannot be anything else. This is not a CTO. There's no collateral, there is nothing. There is also no collateral to the RCA. This is a double thrombotic occlusion. You see, the guy has a double MI, inferior, anterior, at the same time. I've never seen this. It's the first time. Have you seen this in your life?
No.
Never seen this.
maybe because I think that the convert is the LED, but when it comes to CME, the pressure down, so because still have a lesion on the RCA on very tight, in the RCA, it makes some thrombus after that and makes the
I
second.
think, as you say, I think the
Seconds.
primary is the LED, and then he probably has a critical RCA stenosis, and then secondary he is thrombosis.
Because the flow is very slow, still
I agree.
Chồng.
Okay,
Okay.
okay. That's it.
Thank you so much for the interesting case that you present today. Mới đẹp bạn được.
Thank you.
Em chắc là mình cho ông ăn chút đi nha. Rồi. Thấy không? Rồi. Em ăn. With Vietnamese longer. And also Star
Apple.
Star Apple.
Oh.
I just remember the last year I also make you cry. Yeah, maybe cut it down.
Okay.
Yeah, cắt ngang. Why don't you try?
Mà bạn đi